Welcome to This Explainer, where we're going to dive right into the true medical realities of Ebola disease. For decades, dramatized movies and sensational headlines have painted this very specific, terrifying picture of the virus. But today, we are totally replacing that Hollywood fear with grounded, factual reality derived directly from World Health Organization data. We're going to break down exactly what this virus is, how it actually operates, and how modern medicine is successfully fighting back.
Okay, here is our roadmap for today. We'll be looking at the reality of the disease, how it spreads, symptoms and diagnosis, modern treatments, stopping an outbreak, and finally, the road to recovery.
Section 1. The reality of Ebola. To really understand Ebola, we have to look at the numbers, and this one is pretty significant. The average case fatality rate sits right around 50%. Now, historically, that number has swung anywhere from 25 to 90%, depending on the specific outbreak. But here is the absolute crucial takeaway. It's not just about the mortality rate. Early, intensive supportive care, specifically rehydration and symptom treatment, massively improves a patient's chances of survival. Getting care early isn't just helpful, it's literally life-saving.
Now, this disease didn't just suddenly appear out of thin air recently. It first emerged way back in 1976 in two simultaneous outbreaks. One struck in Zara in what is now South Sudan, and the other hit Yambuku in the Democratic Republic of the Congo. That second outbreak happened in a village situated right near the Ebola River. And yeah, that's exactly where the disease gets its name.
So the virus family tree, what scientists call the ortho-ebolavirus genus, is actually kind of complex. 6 species have been identified in total, but only 3 are known to cause large outbreaks. But here is the catch. We only have approved vaccines and treatments for the specific Ebola virus species. For the other 2 major ones, the Sudan and Bundibugyo viruses, we don't have any approved therapeutics yet, though candidate products are actively in development. This distinction is absolutely vital for officials when they're managing different outbreaks on the ground.
Section 2. How the virus spreads.
So how does it actually get to us? Well, it begins in nature. It's thought that fruit bats are the natural hosts. The virus spills over into humans when people come into close contact with the blood or bodily fluids of infected animals, like bats, monkeys, or forest antelope that are found ill or dead in the rainforest. Once that spillover happens, human-to-human spread occurs through direct contact with the bodily fluids of a sick person or even contaminated surfaces. And just to be crystal clear, it does not spread through the air. Now, here is a fact that debunks a massive public misconception. You absolutely cannot catch Ebola from someone who isn't showing symptoms yet. A person only becomes infectious once they start feeling sick, and they remain infectious as long as their blood contains the virus. That single fact is basically the cornerstone of how public health officials track and contain outbreaks.
Section 3. Symptoms and diagnosis. Before any actual sickness appears, the virus goes through an incubation period. This is a stealthy window ranging anywhere from 2 to 21 days. During this entire stretch, the infected person looks and feels completely normal. And as we just learned, they're entirely non-contagious until that interval ends and the symptoms finally kick in.
And when those symptoms do begin, it's rarely what you'd expect. Dramatized media gets this so wrong, usually portraying immediate, severe bleeding. The reality? Early symptoms are incredibly sudden but super generic. We're talking fever, fatigue, muscle pain, and a sore throat. It perfectly mimics other common diseases like malaria or typhoid. Internal and external bleeding actually happens much later in the progression of the illness, and it's a much less frequent symptom overall.
Because those early clinical symptoms are so ambiguous, doctors obviously can't diagnose Ebola just by looking at someone. They have to rely on really advanced diagnostic methods, like genetic RT-PCR assays and antibody ELISA testing. And since the blood samples from these patients pose an extreme biohazard risk, this testing has to be conducted under maximum biological containment conditions by highly trained laboratory staff.
Section 4. Modern treatments and vaccines. Even if a patient is infected with a strain that currently has no specific targeted drugs, hope is absolutely not lost. Providing what the WHO calls optimized supportive care is the very foundation of survival. This means aggressive early rehydration, expertly managing pain and nutrition, and treating co-infections like malaria. This fundamental medical support maximizes the body's own natural ability to fight off the infection.
But for the specific Ebola virus species, our arsenal is much, much stronger. We now have powerful WHO-recommended monoclonal antibodies like MAB114 and REGN-EB3, plus approved vaccines like Ervobo, which are used to protect frontline workers and communities.
For the other species like Sudan and Bundibugyo, well, the fight continues. We don't have approved tools yet, but active core protocol clinical trials are actively paving the way for future vaccines and therapeutics.
Section 5. Stopping an outbreak. Actually containing this thing once it starts requires a strict, comprehensive package of interventions. You need to isolate and care for the sick, rigorously protect the healthcare workers who are facing enormous risks, and identify literally anyone who had contact with a patient. Those contacts are then monitored every single day for that maximum 21-day incubation period. If they show even a slight fever, they are immediately isolated, snapping the chain of transmission right then and there.
But here's the absolute truth. All the advanced medical tools and surveillance grids in the world will completely fail if the community isn't on board. Community engagement is critical. For example, traditional burial ceremonies that involve washing or touching the deceased are massive transmission vectors. Communities have to be actively involved, informed, and willing to adopt safe and dignified burial practices if we want to truly stop the spread.
Section 6. The road to recovery.
Surviving the virus reveals a highly unusual and frankly fascinating biological concept. The human body has what are called immune privileged sites. These are specific areas like the testicles, the inside of the eye, and the central nervous system where the immune system operates a bit differently. The virus can actually hide and persist in these areas long after it's been cleared from the bloodstream. This perfectly explains why, in very rare documented cases, a survivor can actually experience a relapse.
Because the virus can persist in bodily fluids, for instance, transmission via infected semen has been documented up to 15 months after clinical recovery, survivor care programs are vital. We must show survivors profound respect and compassion as they face severe psychological and physical after effects, also known as sequelae. But public health-wise, we also have to provide biological testing, counseling on safer sex practices, and specialized care for pregnant and breastfeeding mothers to ensure the virus stays totally contained.
Which really brings us to our final thought today. Our optimized supportive care, our 21-day contact tracing, and our community engagement strategies are stronger and more refined than ever before. But as we saw earlier, the absence of approved countermeasures for species like the Sudan and Bundibugyo viruses leaves a massive gap in our armor. It leaves us with this vital question. When the next spillover event inevitably occurs, will our ongoing clinical trials yield the tools we need in time? It is a constant race between viral